Thanks, Maureen. So good morning, everyone, again, and thank you for coming to our presentation on addressing medical mistrust and addressing disparities in the utilization of end-of-life care, which will be presented by my colleague, Maureen Burns, Kim Downing, Executive Director, and Candace Draw, which is me. Next slide. So this is just a picture of all of us. You know, we have we took shots at HAP. So this is Maureen, this is me, and that is Kim Downing. So we're all here on the call, eager to address medical mistrust and the things that are barriers for communities of color. Next slide.
Candace, I think we're just going to introduce ourselves real quick.
Oh, is this what?
Yeah, sorry.
So me, I am the Chatham and Inglewood Community Health Education Associate and Research Liaison for the HAP Foundation.
Yes, and I am also a community health worker and community education associate and research liaison. I work mostly on the north side, Rogers Park and Westridge.
And my name is Kim Downing, and I'm also with the HAP Foundation. I am the Director of Program Evaluation and Research, and I also coordinate the Community Health Worker Program, which I will add is my favorite part of my job.
So in our presentation, we are going to here are some objectives. We're going to define health disparities and social determinants of health, understanding hospice care and its benefits, discussing the current disparities in hospice utilization by racial group, and also learn about the history of medical abuse, discrimination, and exploitation, how it impacts hospice utilization rates in communities of color. We will also discuss current issues of inequitable care and provider bias. And finally, we will explore policies, best practices, and strategies to become trustworthy and address utilization disparities in hospice care. Next slide. So before we get started, we wanted to make sure that we respected the Indigenous land acknowledgement. Chicago is situated on the traditional homeland of the Council of the Three Fires, the Ottawa, the Ojibwe, and the Potawatomi nations. Many other tribes like the Miami, Ho-Chunk, Meomi, Sac, and Fox also call this area home. We want to emphasize that Chicago continues to be home to many Indigenous people who continue to practice their heritage traditions and care for their land and waterways. Next slide. So let's talk about health disparities. You know, what are they? Who is affected? Prevalence, and why do they even matter? Next slide. So here are some social determinants of health. When you talk about individual factors like age, gender, genetics, and then you go into individual behaviors, public service, infrastructure, living and working conditions, social and economical and political factors, there are many things you have to take into consideration, and age, gender, and genetics is a big part of that. Access to food, access to housing, social networks, wages and benefits are big ones. Having proper access to safe housing, also segregation, racism, sexism, those things play a big part into our social determinants of health. Addressing poverty is another one, inequalities, and just having addiction issues, coping. These are all factors of the social determinants of health that we're working hard to address. Next slide. So here's a quote that we got from Addressing Inequities in End-of-Life Planning and Care. Perhaps it goes without saying that the inequities historically underserved communities face throughout life continue through the end of life. And at HAP, one of the things that we really stress and that we are really working towards is dying with dignity. And when we talk about inequities that underdeserved communities have faced, this historically goes back generations. And so one of the things that we are trying to, and we're continuing to address, is how to have people die with respect. Making sure that their wishes are properly aligned for, that the doctors that are caring for them, that they hear their concerns, that they have proper people in place to advocate for them, that they have access to issues, and that they have access to resources that they need throughout the end of life. I think that all any of us can ask for is to have a good life and then have a life that ends with dignity.
And now I'm going to pick up here and just talk a little bit about hospice care and what it is. So just by way of background, how I have developed some passion for hospice and palliative care. I'm a former pediatric intensive care unit nurse and was particularly impacted by multiple children that died during the time I worked in the pediatric intensive care unit. And so transitioned and worked for a number of years as a pediatric home care and pediatric palliative and hospice care nurse. When I left that role, I actually went to law school and practiced for a couple of years before I realized I was not being very filled up by corporate law. And so I then went on for about a decade to lead a pediatric coalition in Illinois that's called the Greater Illinois Pediatric Palliative Care Coalition. And it's a nonprofit organization that actually came under the auspices of the HAP Foundation when it was formed. And this organization sought to change the model of care for children with serious illness to better reflect their needs. And so I just share that so you can kind of understand where some of the passion comes for me about people being able to access hospice and have hospice care as an option if they would like to use that care. I think there's a lot of misunderstanding about what hospice is. I think people often think that hospice means giving up. I think people think hospice is a place. So I want to just try to set us pointed in the right direction about what we're talking about when we use the word hospice. So hospice is a model of quality, compassionate, holistic, end-of-life care. The goal is to enable patients to be comfortable and free of pain. And when I say pain, I mean physical pain, but also spiritual pain and emotional pain, so that they can live each day as fully as possible. When a person selects hospice, it does mean that their goals of care have changed. They're no longer looking to pursue aggressive curative therapies for their serious illness, and they have made a decision to pursue more purposefully quality of life and comfort measures. Hospice is delivered by an interdisciplinary team of providers. It is by nature an interdisciplinary service. And those providers often include a physician and a nurse, but also a chaplain, a social worker. We often have expressive therapists, massage therapists, certified nursing assistants. And I think it's important to add that it's a patient and family-centered care. And so the team includes not only the health professionals, but also the patients and their family and their loved ones. Hospice is not a one-size-fits-all situation. It's going to look different for each individual patient and family, and it should be customized to fit a family's goals and their values. I think I'll add the support for family members is really one of the greatest things about hospice, because when a person is sick or when a person is dying, it doesn't just affect that person, but the family unit and the people that love them and the people that are around them. So the support for family members that's part of hospice is just a really critical element of the work. And hospice is delivered where a person resides. So about 95% of the time, that's in a person's home or their apartment where they live, or it could be a nursing home if that is where a person resides. There are some minor exceptions to that. There are hospice inpatient units where people might go if they're having symptom burden that's difficult to manage in the home. But traditionally, hospice is delivered to someone in the place where they live, so they're able to stay in their home environment. Next slide, please. So just really briefly on hospice eligibility. To be eligible for hospice, a person must receive a certification from a physician that they have 6 months or less to live and that their goal of care is no longer cure. So just keep in mind that prognosis is an estimation. Physicians are not genies in a bottle. So although an individual may be certified as having 6 months or less to live, it's possible that they could live another 18 months and hospice care could continue during that time by a recertification process. To be eligible for hospice care, a patient must no longer be pursuing cure as their goal of care. So hospice eligibility does include a decision to forego curative therapies related to that underlying disease. As a nurse, I always feel like that requires a little bit of clarification. So if I have a cancer diagnosis and I decide to use hospice, I would no longer pursue curative chemotherapy. However, I might still receive palliative chemotherapy to reduce my tumor mass for comfort. And additionally, if I was on a heart medication prior to being admitted to hospice, I would continue on my heart medication because it's not related to curing my cancer diagnosis. So I just share that because I think there's sort of this myth or this thought that when you go on hospice, you just give up and stop everything. And that really could not be a further statement from the truth. It's really a goals of care issue. Most private insurances do offer the hospice benefit, and it is a benefit of Medicare and of Medicaid in Illinois. There are many hospices that offer care philanthropically or charity care for individuals that do not carry insurance. And hospice is now covered for undocumented seniors in Illinois through the health benefits for immigrant seniors and adults program. So there really are wide coverage options for individuals to receive hospice care. Just really briefly, palliative care is something that is like hospice, but it is different. Palliative care in the community is often delivered by a hospice organization, but I just want to differentiate it because I think the two terms are often used together. Palliative care is a type of care that can actually begin at the time of diagnosis with a serious illness. It's primarily for symptom management, again, physical, emotional, spiritual. So a person would continue to pursue their cure fully, continue in a curative direction, but also receive palliative care. People often can be discharged from palliative care. They receive a cure, they've been cured or no longer require symptom management for their serious illness and they're discharged. Or there could be cases where a serious illness could progress and the person could be transferred different situations. And from a technical perspective, it has different billing mechanisms. And so it makes it a little less widely available for all people. So just end this slide by quoting an often said thought in the hospice space, and that is that the end of life deserves as much care, respect, and beauty as the beginning. So having been part of hospice care for many years, I will say it's an honor to be with families during this really personal and potentially very beautiful time. And I don't mean to get too philosophical with us on this Friday morning, but each and every one of us has a 100% chance of death at some point. And so I feel really strongly that everyone needs to at least understand hospice, what it actually is, what it does, how we could access it. So they're empowered to make a choice, to make an educated choice if that is something that they would be interested in utilizing. Next slide, please. So here we're going to dive into looking a little bit at hospice utilization by race. And this is data that was provided by the National Hospice and Palliative Care Organization. And it shows Medicare beneficiaries by race who died and the percentage who utilized hospice care prior to their death. So you can see among Medicare beneficiaries, nearly 54% of white individuals used hospice, but that statistic is only 43% of Latinx individuals, 41% of Black individuals, 40% of Asian individuals, and 39% of Indigenous people who utilized and accessed hospice care. So really in all categories, utilization could be higher, but notably, the rates among racial minorities indicate that they may be experiencing some barriers to accessing care. Next slide, please. So we want everyone to have equal access and equal opportunity to access hospice care. So the goal is really to ensure that every person, regardless of race or ethnicity, understands how hospice can serve them and their loved ones. Hospice users, and this is important because hospice users report higher quality of life, higher levels of comfort, lower levels of pain, and they also actually live longer compared to individuals with similar disease processes who do not use hospice, which I think surprises a lot of people. But once good pain management is in place and people feel they're getting the support they need, we find that we do see a longer life for those individuals. Also, terminal illnesses, serious illnesses can be really hard on family members, friends, and caregivers. So the holistic support and grief services that are offered by hospice benefit and impact not just the patient, but all of those around them, their family members, their loved ones. And most hospice patients, since they remain at home, expert care comes to them. It allows them to stay comfortably in their home, and it also prevents unnecessary hospitalization. And so in that way, enrollment in hospice really ensures that patients aren't subjected to painful procedures or aggressive treatments that do not benefit them. And just in closing on this slide, just because a disease is not curable, just because we cannot find a cure, there is still so much that can be done for patients to support their physical, their mental, their emotional, their spiritual health. Next slide, please. So this slide really demonstrates some of the impact of disparate access. This is a study that showed how many days people spent in the hospital during the last year of life. And you can see that as compared to white individuals, Hispanic individuals spent 5.6 more days in the hospital during the last year of life, and Black individuals spent 8.2 additional days in the hospital in the last year of life. Next slide, please. So to move kind of into disparate use of services, studies are consistently demonstrating lower rates of hospice use for minority older adults as compared to whites across diagnosis, geographic area, settings of care, including within nursing homes. So, this study is telling us it's not just location, it's not just an area of the country, it's not just urban versus rural, but across multiple domains, there are disparities in utilization of hospice care. And the second statistic here is just something similar to what I touched on earlier. This one's from 2010. And I think it kind of shows we've made very little improvement, but it demonstrates again, continued disparate use of hospice care among Medicare beneficiaries. And so I think the question becomes, why? Is this related to personal choice? Maybe sometimes, but I think there is some evidence that we can look at and see in the research, and also from what HAP is beginning to learn in our own experience, that really begins to lay out a story that there is disparate access to conversations and to options that would allow individuals and families to remain at home and to utilize hospice care. Next slide, please. So again, we're looking at why the disparity. Well, one thing the research is showing is communication. Empathetic communication is such an important part of hospice and palliative care. And so this first quote is from a study of cancer patients evaluating communication that showed the quality of dialogue differs by race with end-of-life discussions, and that physicians were actually less likely to participate in conversations that resulted in care being consistent with the preferences of the Black patients. So here's a study showing that one of the critical elements for understanding goals of care, for understanding patient desires, conversation and communication has inherent quality disparities lodged within it. And the second study referenced on this slide also looks at a communication failure. So hospice, and I am not a Spanish speaker, I wish that I was, but hospice translates or sounds very much like the Spanish word, and you'll have to forgive me because I'm sure I'm not going to say it correctly, but hospicio in Spanish, which means an orphanage or a place for poor people. And so patients and family members, therefore, may interpret it as substandard or inadequate treatment. And so why would you want to use something that you perceived or understood to be described to you as substandard treatment? Next slide, please. And then just to touch briefly on advanced care planning, another reason for disparate access is planning. We are finding that so much of good end-of-life care has to do with conversations with family members about desires for care, and conversation about desires with doctors and what options might be. And advanced care planning is a critical part of that. So on this first slide, advanced care planning studies reveal that among the population surveyed, only 18% of minority participants had completed advanced care directives, while 34% of white respondents had. So we're seeing disparities in the documented results of conversations, and that those documented results really do impact care decisions and therefore hospice utilization. And I think too, just to touch on structural racism, this is an issue that extends from hospice back into the serious illness space. And this second quote on this slide comes from a recent article that was just released this year, showing that Black veterans with chronic kidney disease experienced racism in the clinical setting that produced physical and emotional stress and a strong sense of distrust in the healthcare system. So I also want to share that HAP has begun to do some work in this space. We are very passionate about access and disparate access to hospice and palliative care. And we're currently engaged in a research study in partnership with NORC at the University of Chicago. So I'm going to pass the mic over to Candace for just a minute, who has a leadership role in this work. So she can share a bit with you about the work we're doing to continue to understand these disparities in partnership with NORC.
Thank you, Kim. So in partnership with North U Chicago, I had the opportunity earlier this year to sit on a panel with some researchers. And from that panel, I was actually privileged and glad that they chose my idea in partnership with the HAP Foundation and North U Chicago about Black Americans and end-of-life perceptions, basically how we as Black people view hospice and palliative care, our experiences around it, and what we have, and even caregivers who have taken care of people towards at the end of their life. And in some of our initial findings have been very startling, but as Kim mentioned, the lack of distrust was very, very high as being one of the pointers. The second one was culturally appropriate conversation. Doctors not having proper bedside manner, not expressing things in a culturally appropriate way, not even having the training to speak to certain communities, especially among Black people. Not given the same treatment as others were, no consideration for care towards the end of their life. There was a patient that was on dialysis, and his spouse really expressed how she really felt she was being disrespected, how he was being disrespected towards the end of life. People, as I mentioned earlier in the social determinants of health slide, who don't have access to proper insurance for whatever reason that might be, treated more as a guinea pig than they were as a person. So those are just some of the things that we found in our initial findings as we have, done this project through NORC. And it's my hope that once, we have wrapped things up, that we can disseminate this research into smaller hospices, smaller hospitals, and to let them know that this is a place of focus as to where you need to address. And it's not just for Black people, it's for, Latinx communities, it's for Asian communities, it's for underserved communities to know and understand that while the privilege may not be there, the respect still needs to be there. The consideration still needs to be there, no matter what my diagnosis is or no matter what it is that I'm facing. So that's the gist on our research project through NORC. Thanks, Kim.
Yeah, no problem. And before I pass it to Maureen, I'll just add too, the findings from that study are going to be posted on the HAP website in our research section, probably by March 2023. So if you're interested in the executive summary from that, please visit our website in the spring, and that information will be posted up there.
Great, thank you, Candace and Kim, because I think that research study is really going to yield some very important results, and then more importantly, kind of putting those results into practice, especially with providers. So I'm going to start now by talking about some of the potential causes for these utilization disparities. So why is this happening? And there are a lot, but one is a lack of trustworthy providers, medical mistrust and discrimination. That's what we're mostly going to focus on today. But then also, as was mentioned by Candace, a lack of diverse and culturally competent providers. So having a provider that looks like you or lives in your neighborhood can make a big difference. And if that's not possible, at least having a provider who has been trained in cultural humility. Also, language capacity and cultural attitudes. It's very hard to receive this type of care. Providers don't speak your language or don't understand your culture and what matters to you. And then finally, a lack of awareness of hospice and education on how to access it. So Kim touched on this. There's a lot of misunderstanding and a lot of stigma associated with the word hospice. And so Candace and I will talk later about how that's part of what we do is provide free community education that explains hospice. So as I said, we're going to focus a lot on the medical mistrust piece. And when we say that, we are talking about so many things. I could probably do like a 5-hour seminar just on medical mistrust. But once we go through each bullet point, we're going to start to see that there is a very long legacy of our healthcare system in general, proving itself to be untrustworthy. So it's really important that we not frame medical mistrust as something that communities of color need to get past. It is really something that we as a country, as a medical system, as providers, as people involved in this space need to reckon with and address. It's really on us to fix this. And in many ways, medical mistrust is absolutely warranted. As you're going to see, we're going to go through some of the history. Some of you may be familiar with it and others may not. But I think it's important for providers and anyone working in the medical space, and especially in end-of-life care, to understand that every single time we have an interaction with the patient, they are bringing with them all of their prior experiences, all of their perceptions, the way they've been treated in the past, and sometimes the experiences of their family members or ancestors and how they have been treated. So we're going to talk about medical abuse and experimentation throughout history, historical racism and discrimination in healthcare, as well as current discrimination and inequities that persist today. I do want to give a little bit of a trigger warning. We are going to be discussing a really tough topic, a devastating history that includes genocide, enslavement, exploitation, medical experimentation, and abuse. So I just want to put that out there that it might be hard for some folks to hear this. And we are presenting this not for shock value, but because, we need to be honest about what has occurred in order to reckon with it and to do better and to understand the experiences of our patients. So I'm going to start just talking a little bit about colonization, genocide, and experiments on Indigenous peoples. So it's pretty well known that many of the Indigenous tribes of the Americas were decimated by European diseases. Sometimes that just happened because they didn't have immunity to those diseases, but sometimes it was actually intentional, including in 1763, which was the first documented case of the US military using biological warfare, when they intentionally gave out blankets to Indigenous tribes that were infected with smallpox. And then moving a little bit forward in the history, between 1819 and all the way to 1969, the US ran or supported about 400 residential schools. And recently there's been a lot more recognition of that history and a lot more reckoning. But basically Indigenous children were forcibly removed from their families and they were sent to these boarding schools to be forcibly assimilated. So there was a lot of a trauma associated with that. Poor sanitation, many children died of diseases or suffered physical or sexual abuse. There's also some evidence that some of those children were also used in medical experiments. specifically when it came to ophthalmology. The Proctor Foundation performed some testing on students between 1967 and 1973 as they were testing treatments for an eye disease called trachoma. And then in the 1960s and 1970s, the Indian Health Service sustained a practice of performing sterilizations on Native American women. And in many instances, this was done without their consent. Sometimes children as young as 11 were sterilized, and some people were falsely led to believe that the procedure was reversible. So it's important to understand this legacy of many hundreds of years and how it has contributed to mistrust and also a continued lack of access to care and to resources within Indigenous communities. And another way in which the Indigenous community and also other communities were very much harmed under the auspices of healthcare was during the eugenics movement. So as some of you may know, this movement was roughly from 1907 to 1963. And it was really this idea of the time that we could improve the quality of the human race by encouraging certain folks with desirable traits to reproduce and discouraging those with weaker traits from reproducing. And of course, eugenics reinforced the racism of the time. So it often deemed desirable genetic traits as white traits, and undesirable traits were associated with people of color, people of lower economic status, or people who are physically or mentally disabled. And so in the US, the eugenics movement was really focused on what we call negative eugenics. So a focus on preventing those people who had been labeled as having undesirable traits from reproducing. So the first eugenics-based compulsory sterilization law was passed in 1907 in Indiana. And eventually 30 different states would follow their lead. So it's estimated that in this time period of 1907 to 1963, over 64,000 people were forcibly sterilized under these eugenic legislations. And of course, the people who were disproportionately impacted were people of color, including Indigenous folks, African Americans, Puerto Ricans, and also people who were incarcerated or people who had real or perceived disabilities. This brings us into discussing the era of slavery and how Black individuals were exploited. I think it goes without saying that, of course, during the era of slavery, enslaved people were not considered people, right? And so they were thus denied medical care. And in many instances, they were also, abused or experimented upon. And also in the 19th century, the US medical education system, so talking about medical schools, they really had a need for cadavers for experiments, and they had a sustained practice of robbing Black cemeteries to obtain those cadavers. So this goes to show that not only has the medical system proven itself to not be built for Black individuals, it's also shown a blatant disregard for the dignity of corpses, of graves, of all the things that kind of go along with the end of life and how we memorialize folks. And so also talking about experimentation on enslaved people, you may have heard of Marion Sims, who's often known as the father of modern gynecology. Unfortunately, all of his pioneering techniques related to reproductive health were born from the abuse and mutilation of enslaved Black women. So he tortured innocent Black women on his surgical table using primitive tools and no anesthetic. He sterilized them, mutilated them, all in the name of science. And then fast forward to 1927, we have the Lyle Station radiation experiment. So this was an experiment in which 10 African-American students were chosen to be part of what was touted as a study for ringworm of the scalp. But they were not given ringworm treatment. Instead, they were exposed to high levels of radiation as part of an experiment. So as you can see in the photo, the radiation caused disfiguring scars, malformations, and emotional trauma that the victims dealt with for the rest of their lives. And then the third bullet point here, I think, is perhaps the study that people are most familiar with, which is Tuskegee syphilis experiment. So I'm not going to spend a whole lot of time on this just because I feel like this is the most well-known instance of medical abuse, but essentially about 600 poor and mostly illiterate African-American males, 400 of whom were infected with syphilis, were monitored for 40 years, basically so researchers could just watch how the disease ravaged their bodies, and they were denied treatment and lied to while the disease was allowed to progress. Also want to talk about 1951 and Henrietta Lacks. So this is another instance of exploitation that has recently, I think more folks have become aware of. So Henrietta Lacks was a Black cancer patient. Her cells were harvested without her consent. And those cells ended up being remarkable, and they became the first human cells to be cloned. They're now known as HeLa cells, and they're considered a crucial tool of biomedical research. They've been used in everything from in vitro fertilization to the COVID-19 vaccine. And because of this, her cells have been sold for millions of dollars. So her descendants are involved in a legal battle to try and get some compensation for the fact that her cells were basically stolen and other people continue to profit off of them. Then from 1960 to 1971 is the Cincinnati experiments. This was a radiation study funded by the US Department of Defense. They wanted to study how soldiers in a nuclear war would be affected by radiation. So these experiments were conducted without patient consent during the first 5 years of the study. Involved 88 cancer patients from ages 9 to 84. And they were intentionally exposed to intense doses of radiation. Their physical and mental responses were recorded. Many of those patients who were mostly Black and mostly poor died of radiation poisoning. And then a very recent instance of experimentation would be the 1993 Baltimore lead paint study. So this was a prominent research facility associated with Johns Hopkins. And they conducted an experiment that knowingly exposed mostly Black children to varying levels of potentially dangerous lead. It was part of a study comparing different types of lead paint abatement. So they recruited poor families to move into homes that had only been partially abated using these 3 different methods. And then, of course, talking about in history, and especially in the history of segregation, so from the time period of Reconstruction through the Jim Crow era, it's pretty well known that African Americans were basically legally oppressed. And this hindered, their ability to live fully and equally in society with whites. This was also especially true in terms of healthcare. So there were segregation laws that separated Blacks from the rest of society, including in hospitals. And so, as is often the case in segregation, it is not separate but equal. It's definitely not equal, and many of the Black hospitals were poorly funded. So the fight for civil rights and integration is pretty well known, but what is lesser known is kind of the medical aspect of that. So Black physicians played a really integral role. There was something called the Medical Committee for Human Rights, which was kind of like the medical wing of the civil rights movement. And this was a group of Black physicians and healthcare workers who really dedicated themselves to ending segregation and the substandard medical care for Black folks. As was expected, Southern governments did everything that they could to prevent integration of hospitals. including threats and acts of violence by the KKK. And really what ended up being the push towards integration in medical facilities was Medicare. It wasn't until the federal government had all these Medicare dollars and Medicaid dollars that they could kind of bargain with and say, you know, you're not getting any of these dollars unless you integrate your hospitals. And so then moving now more into the current times, unfortunately, we still see discrimination and inequities. So we talked about the social determinants of health, how our health is much more than just our age and our genetics. It has everything to do with our living conditions and our access to resources, and of course, systemic issues like racism, sexism, ableism. We also have to contend with implicit bias, which I'm sure most of you had heard of. This is kind of refers to attitudes that are activated automatically without an individual's awareness. It's not intentional, it's kind of an invisible stereotyping that happens automatically. So you may have seen that popular YouTube video that explains implicit bias. Basically, like if I say peanut butter, most of you are going to think jelly, because we've just sort of been conditioned to think of those two things together. So no one is immune from implicit bias. We have all come up together in a white supremacist system, and we've all been exposed to stereotyping in the media, and it becomes ingrained in us. And so lately, also, we have heard about, especially with the COVID pandemic and, you know, the politics and polarization surrounding vaccination, we've heard a lot about trust the science. You know, science is fact. But it's important to remember that science is not immune, right? Science and research is influenced by the biases of the people working in them. And, you know, going back to previous slides, at the time, you know, eugenics and other racist sort of junk science was considered valid. So I think it's just important for those of us who are in healthcare, science, public health, medical field, you know, to be cognizant of whatever biases we may have and to work to address them. Also, several years ago, there was a research study through the University of Virginia, and they probed the beliefs of white medical students. And they found that almost half held false physiological beliefs about African Americans. So almost 60% of these medical students thought that African Americans had thicker skin than white Americans. 12% thought that the nerve endings of African Americans were less sensitive than those of white people. And this plays in, those attitudes, which are shocking, plays into other study results that have documented that Black and Latinx patients are less likely to have their pain sufficiently managed. So that's an example. If medical students falsely believe that some people of color do not feel pain in the same way that white people do, you can see how that then translates in the real world to those Black and Latinx patients not getting proper pain management. So this is a huge issue that is not in the past, it's happening right now. So I just talked about a lot of really horrific history, as well as current issues that are happening right now. But I also want to tell a story about a real person whose name I've changed. I'm going to call her Tanya. But so Tanya is a Black woman living in Chicago, born in the 1940s during Jim Crow segregation. And as a Black woman, she had a life that was full of lived experience with discrimination. But more recently, she was diagnosed with uterine fibroids, which you may be familiar with, which causes pain and bleeding. And so when she went to her doctor to seek treatment, she was told that she should have a hysterectomy, have her uterus removed. But she was concerned about that, major surgery. So she acted as her own advocate and sought several different second opinions. Finally, on the fourth doctor, he let her know that she did not need to have a hysterectomy. There was a less invasive procedure that would fix the problem. And so I share this story just to say that self-advocacy is exhausting. And the more times individuals go to a provider and they get substandard care or substandard conversation or substandard advice, it reinforces to them that they don't matter in the eyes of this provider. And so if we fast forward, going back to Tanya, about 10 years, and she is diagnosed with terminal cancer. Her doctors don't believe that she can be cured and they recommend hospice care. How do you think she will respond? She has a history of doctors recommending treatment to her that is substandard. So it's quite likely that when a doctor recommends hospice care, she is not going to believe it's appropriate. She is going to believe that those doctors are giving up on her, that they don't want to cure her, and that they're just going to let her die. So I'm going to come back to her story later in the presentation, but I just encourage you all to kind of think about those implications, how she might respond to that suggestion of hospice, and will she have reservations about hospice care? And so finally, the last slide I'm going to talk about right now is also mistrust in immigrant populations, which I think we haven't touched a lot on. We've really focused on indigenous and Black communities. But it's also important to remember that the US has a large immigrant population, and each individual brings with them good or bad experiences with the medical system in their home country. Sometimes the medical system in their home country may be vastly different from the one we have here in the US. Refugees and asylees especially may carry trauma from past experiences, and that can impact their trust here in the US. It's really important that we remember that hospice is still a young movement, both in the US and globally, and it's less prevalent in certain areas of the world. So this means that many immigrants may have no idea what hospice is or what it means. And it's also important to understand that immigrants come here on their journey and they bring with them their own sets of beliefs and cultural norms. So there are a lot of cultural differences when it comes to end of life and death and dying. And then also the issue of language capacity. There's between 350 and 430 languages spoken in the US. Here in my community of Westridge, we have over 40 languages spoken regularly. So it's really hard for people to utilize services if the providers don't speak their language. And then the final issue is the fear of accessing health coverage due to public charge implications. So undocumented folks have a fear of deportation, fear of public charge implications, and that often stops them from accessing healthcare. So part of this issue is that public charge laws changed under President Trump. And even though President Biden reversed those changes, there's still a lot of fear that remains about accessing Medicaid, SNAP, or other government programs. So now I'll throw it back to Candace, I believe.
Yes, thanks, Maureen. So here's some implications for hospice care. My colleagues both know that I'm a lover of quotes, and so in our presentation, I'm glad that there was a lot of quotes, emphasized in the presentation that went along with what we were discussing. So historical discriminations against communities of color has resulted in an understandable distrust of providers that continues to be an important barrier to accepting a poor prognosis, entertaining hospice enrollment, or perceiving palliative care as something other than second-tier care. Just that point right there alone is something that we have found in our NORC study, that palliative care is something other than second-tier care. We found that people don't understand the difference between hospice and palliative care, and also that some people have the terms mixed up. Some people think hospice care is palliative care. Some people think that palliative care is hospice care. So that community education that we'll talk about later on is something that's much needed in certain communities. And trust is an essential ingredient to quality end-of-life care, and the lack thereof remains a durable barrier to achieving that goal in many other communities. I recently learned about a study that was done some years ago in Atlanta where Black people who were in their end of life were more apt to open up to their physicians if there was a level of trust that had already been established. Once the level of trust had been established, then the spirituality aspect came out about how they wanted to live their end of life. But until that trust was there, they were very less likely to open up. Next slide. So, and then here's some impacts, some pointers that we wanted to talk about impact of mistrust on end-of-life preferences. So advanced care planning study, only 18% of minority participants had completed advanced directives compared to 34% of white respondents. Again, that can go back to education, making people understand that advanced directives are needed. And while we do not want to talk about end of life, we don't want to discuss certain things, you know, we have to accept the fact that it will happen. And we always say in our community education presentations, and Maureen can echo this, that anybody over the age of 18 can have one. So, and that can be changed as time goes on. I may get married, I may get divorced, I may have other issues. So but it's important to start having those conversations early. And as a group, Black people are far more likely to opt for aggressive life-sustaining treatments at the end of life, and people living in historically marginalized communities in poverty are too busy. Here's another one, trying to survive, that they often don't think about what they want at end of life. This is primarily because it can be very, very difficult to just survive day in and day out. If I do not have proper food, if I just have to eat what is available, if I don't have good health insurance, if I'm just struggling to keep a roof over my head, often medical problems get pushed aside. Not that we don't understand and that we know that it's not important, but because our minds are just focused on survival, I really don't have time to deal with this. That's something that's another big issue. And in many minority communities, care of the dying is the duty of the family. I have written for caregiving.com for a while now. And even in our study with NORC, we found that a lot of times with communities, a loved one gets sick, I step in and I help. We've also seen this in Latinx communities where if a loved one gets sick, we don't really believe in nursing homes, or our loved one has been very expressive and don't put me in a home, don't put me here. So now we've come together as a family, or one person in particular, and as we found it's mostly women that step in and become that person that, takes care of family members and in terms of caregiving. But that can bring a whole lot of other issues that we're not discussing today. But, most of the time the caregiving is done by the women in families. Next slide.
Candace, before we moved on, I just wanted to add to that because that's something I see a lot in my community, especially with communities from Asia and recent immigrants from the Middle East. So just going back to what Kim said, the idea that in hospice care, the family members are considered part of the care team. So we really need to make clear to people that we're not trying to replace the loved ones. We understand that loved ones have a duty to take care of people who are sick, but just that team can provide an extra layer of support. Your loved one is good at keeping you comfortable and bringing you your favorite food, but your loved one can't access morphine. Your loved one doesn't understand about certain changes that occur as a disease progresses. So just understanding and explaining to folks that we are not trying to replace them. We want them to be members of the care team, and they want them to benefit from all the expertise that the hospice care provides. Thanks.
Next slide. So now that we have gone through everything from historical to current issues, how are we going to rectify the problem? So basically, what now? So are there any easy solutions? No, there are not. Unfortunately, when we talk about trauma, historical things, there are no easy solution. However, we can listen, acknowledge, recognize, prioritize, and invest in these communities. Diverse and culturally humble staff is another one. So if we talk about leading with cultural humility, that starts with empathy. And it assist the provider in acknowledging and respecting the patient's individuality. You may not agree with me. You may not like how I'm assessing care. You may not like some of the decisions that I've made, but as a person that is caring for me, you have to respect my decisions. So basically having staff that looks like the person being cared for, having a staff that understands this is key in providing solutions for these problems. Serious illness, continuum of care, and expanding palliative care. I think that it's also important to explain to people early on what palliative care is. I also do a lot of cancer advocacy work. And one of the things that, I see in my cancer advocacy work and in talking to people is that most people who got diagnosed with cancers in later stages did not understand that they then qualified for palliative care, not towards the end. Most people thought that they were dying if you said palliative, not understanding that it's increasing your quality of life, helping you with pain management, helping you improve your symptoms. And sometimes some patients don't stay in palliative care, but the lack of understanding was presented a little bit too late, especially to certain communities. So that's another one. And utilizing community health workers, community education associates, people in the community, call us what you like, but community health workers is very, very key in this as well, because they provide community education, whether it's with nonprofits or in a hospital setting, and they can work similar with patient navigators. Next slide. So let's acknowledge, recognize, and prioritize and invest in these communities. So first step is for all healthcare entities to own their responsibility. So this can be hard for people because it's hard to take accountability, whether it's individual, whether it's as an organization, and some people are very, some will not do that. But if you want trust to come, you have to own the responsibility that you have played in what has happened to certain communities in this country. Prioritize people of color. That's all people of color. Again, whether you agree, whether you disagree, everybody deserves quality care. Invest the time and money needed to do better. That's at a state level, that's at a national level, that's even at a level within where you're working. For things to change, we need to recognize the fact that there have been problems throughout the years that have spread along. And while as a country we've come a long way, we still have to invest the time and prioritize people. And ensure empowerment without paternalism. I don't always need somebody watching over me. I need the room to be who I am, and to be empowered throughout my decisions. And that comes from taking responsibility from all healthcare providers. Next step.
Yes, and just that empowerment without paternalism, I just want to make it clear that, when Candace and I go out into the community and do education about hospice care, we are not trying to force hospice care on anyone, right? If you want aggressive curative treatments until your very last, that is what you should get, if that's what you want. But just making sure people are empowered and they understand all their options, and then allowing them to choose.
And giving them the right to make a decision that works for them and their family. So building diverse and culturally humble staff is another big issue for me. Ensuring, first of all, that all clinicians understand the legacy of medical racism and its impact, especially when you're dealing with certain communities. Expanding the diversity of the hospice workforce, meaning, educate your staff more on what hospice is and how to educate on cultural humility. Again, that's acknowledging and respecting the patient's individuality, and it leads with empathy. Training on addressing implicit bias. When my mother was going through cancer care, and the reason why this touches home for me is because when she was going through cancer care, one of her physicians told her, and I will quote this and I say this, called her stupid for not, and I was sitting right in the room, called her stupid for not taking the course of treatment they felt was best, not respecting the fact that as an individual, I can make my own decision. So having proper bedside manner, knowing how to talk to people properly, and then understanding, well, that's where a lot of the mistrust comes in. You're automatically saying that because I didn't choose to doing, and then thinking it's okay to speak to me like that. That's another one. And I think that something like this can start with medical students. And as being part of their training, whether they shadow people in hospitals, whether they shadow people at the end of life with certain doctors or care teams. I think that this is key. Truly understanding cultural diversity takes a personal journey, and you have to open your mind and heart in order to develop cultural humility. And that requires studying histories of oppression and discrimination, as we have discussed, looking at your own personal assumptions and prejudices that maybe you personally have, and addressing those, and putting your assumptions and including opinions aside when working with clients, and then being respectful to clients. And this is something that also needs to be addressed at the end of life. Respect goes a long way, no matter what culture you're in. And if you need to have that relationship with your doctor where you can be open and talk to them without all of the extra biases against you, especially as a person of color. Next slide.
Okay, so I'm gonna pick it up now, just kind of building upon what Candace just talked about. And another really important solution is expanding the continuum of care for serious illness. So what this means is making sure that patients know all their options. And we've talked a little bit about palliative care, but palliative care can be really important because we also learned in this presentation that specifically Black people tend to utilize and desire really aggressive end-of-life care treatments compared to other races. So knowing that, palliative care can really be a great solution because you can get palliative care, you can get symptom management while you are still pursuing curative treatments. So going back to the example that I mentioned earlier of Tanya, who was diagnosed with terminal cancer, and her doctor said, you know, we don't believe this can be cured. We recommend hospice care. She was not ready for that. She was not ready to give up her fight, and she didn't necessarily trust her doctor's opinion. But luckily in that situation, she had a friend who was a nurse, and that nurse knew about palliative care. So that friend explained to her, hey, you could do palliative care and you can still do your chemotherapy. So that is what she opted for, to fight the cancer, despite her doctor's view that, you know, that wasn't going to work. And so for about a year, she underwent aggressive chemotherapy, but at that same time, she was also getting outpatient palliative care. So that meant that she had a palliative care team that helped her manage her pain and also manage the side effects that came with the chemotherapy. And of course, also helping her through the emotional roller coaster that is a cancer diagnosis. And so after a year had passed, Tanya on her own came to the decision that she wanted to stop chemotherapy and that she was done. She opted for in-home hospice care. This is an example of how making sure that people understand that palliative care exists and also expanding coverage for palliative care really helps with hospice utilization rates. Because even though Tanya's doctors were ready right away to jump to hospice, and she probably would have been eligible for hospice based on that prognosis, she was not ready. And what palliative care offered her was the same symptom management and support of hospice care without having to stop those curative treatments. And another important piece of this is along the way, you know, while she's fighting the cancer and she's getting palliative care, she's starting to form a relationship with that palliative care team. And assuming that they do everything we just talked about in terms of cultural humility and respect and empathy, she can start to build trust with them. And if those, you know, many times providers who offer both palliative and hospice care. So she has a whole year of relationship building with these clinical folks that then makes her more comfortable to open up to hospice care when she's ready. So this is just an example of how increased touch points and education can really help people utilize both palliative care and hospice care if they so choose. And so part of that is, you know, what Candace and I do, being out in the community and explaining to folks what hospice care is, what palliative care is before they need it, right? Before they have a terminal diagnosis. And this is really key because, as I said, the more we can expand palliative care, it can lead to more opportunities for people to interact with these clinicians and hopefully build trust. And so it's in that way, you know, that increasing utilization of palliative care can also increase utilization of hospice care. Of course, there may be folks who still don't opt for hospice care, and that's totally fine. You know, there are some people who want curative treatments till the end, but we also want to make sure that while they're pursuing those curative treatments, they have access to all that same pain management, emotional, spiritual support through palliative care. We also talked about utilizing community health workers. So Candace and I are both CHWs, and this definition on the screen is from the American Public Health Association. So community health workers go by many different titles. We might be called CHWs, promotores de salud, CHRs, patient navigators, patient advocates, outreach manager. We go by many names, but basically we're a trusted member of a community. And so we really serve as a bridge between the folks in our community and a medical institution or a social service entity, to really link people to service, facilitate access, and also build trust. And so we have a lot of different roles: advocacy, outreach, communication. We're part of the public health workforce doing health promotion. And also a big part of our work is cultural competence or cultural humility. So the idea that we can provide education to our community that is respectful of their cultural norms, and really start important conversations about serious illness, advanced directives, palliative and hospice care, and also grief support. So we can be one tool of many to rebuild trust and serve as cultural mediators. It's important though, because CHWs are becoming very on trend right now. So it's important that, it's not enough as a provider to just hire a bunch of CHWs from the community and be like, okay, we built trust, we fixed everything. That's not enough, right? You have to employ CHWs, but then you also have to empower them and listen to them. Because just as CHWs provide education to the community, we also go back to our employers and we let them know what assets and what barriers exist in the community and what needs to change to better serve those members of the community. We also advocate for CHWs to be members of palliative and hospice care teams. So one of the things that CHWs do is also resource navigation. So a CHW can assist a social worker on a care team, helping make sure that the people in the household have all their most immediate needs met. As we talked about, it's hard to focus on hospice care and a good end of life if you don't have food in the fridge, or if you need daycare for your children, or if someone in the house is unemployed. So having CHWs to offer resources for those issues is really important when families are in crisis. I think back to you, Candace.
Yeah, I know. I think I'm going to bring us home, and I'm going to try to do it pretty quickly here so we can have some time for questions if people have them. So just really briefly to describe the HAP Foundation, we're a nonprofit, independent, mission-driven organization, and we work to improve access to quality serious illness care through education, advocacy, workforce development, and research. And I'm finding that this feels very vague to people. So just a few really quick examples to make it a little bit more concrete. In the education space, we have our community health worker program. So individuals that live in communities going in and trying to educate about hospice and palliative care, what options are, what it should look like, what the benefits of the care are, trying to improve knowledge and ability to self-advocate if that's something someone was interested in the hospice and palliative space. In the research space, Candace gave you an example of one of our projects that we're working on in collaboration with NORC. Another one of our programs is our Missing Pieces Grief Navigation Following Child Loss program. And so we have grief navigators that are available, and they work in collaboration with various local hospitals and also with the medical examiner in Chicago and the coroners in the surrounding counties to be a grief resource for families following child loss. And we found this to be really important because grief support is very difficult to navigate in our region. There are a lot of support groups and a lot of, I should use a lot cautiously. They exist. There could be more for certain, but often they are supporting people by topic. So by suicide loss or by loss related related to sudden infant death, or they're kind of categorical. And so for an individual who is looking for grief support following child loss, to have to call multiple programs and retell their story can often be very re-traumatizing. And so our grief navigators speak to families, and they provide a central kind of location. They hear and hold a family story, and then they identify resources in the grief space and also other social determinant of health issues that might help that family and get them directed in the right to the right place for grief support without having to make 50 different phone calls. So those are just a couple of examples of a few of our programs to try to put a little bit of concrete definition to some of the work we do. Could I have the next slide? And then just really briefly, I have the distinct privilege of leading the research program at HAP, and we're working really passionately to ensure we're implementing community engaged research. And I am sort of in a very different position being part of a community-based organization. I am not a PhD. I'm not an academic researcher. I came into research through community engaged research myself, and have been a community-based partner for multiple different academic research projects. And so at HAP Foundation, we really lean into those academic partnerships for multiple reasons. One reason being IRB access, because we don't have it as a community-based organization without having to pay for it, but also to continue to build the trust and build the relationships between the community-based organizations engaged in community engaged resources, research, and the academic partners. Next, can I have the next slide? And so I think I'm probably preaching to the choir, as they say, but this is just a little bit about our community engaged research approach. We really try to ensure there is leadership from individuals who are in the community we're looking to better understand through research from the very beginning as stakeholders or in leadership positions from the very beginning of the project, from question development through data analysis and dissemination. I think I'm going to stop here. We're essentially done, but I want to leave some time for questions. So we have one slide left that's kind of a conclusion. Maybe we could bring up and people could take a look at that. And then I think, given the fact that we're 10 minutes out from being completed, I'll turn it back over for potential questions that you might have for us.
Yeah, I'm also just going to put this slide up because we do ask folks to fill out an anonymous survey. Candace and my positions are funded by a grant, so we have to turn in survey data. So I'll also try and put that link in the chat, and I'll stop sharing so we can open it up for questions or comments or shares.
Sorry, do you mind going back to the concluding slide, please, if possible?
Yes, 1 second.
Thank you.
This one?
Yeah, thank you.
Hi, this is Boye Ogusheka, the physician from Northwestern. Thank you so much for a very thoughtful, thought-provoking, I would say disturbing, but the truth is often disturbing, and that's a good thing, presentation. As I said during my introduction here, we are really interested in being a part of the solution. And I would like to reach out to you offline to find out how we can better work with you. My colleague, Julie Vermeulen, who's unable to be here today, and I have both undergone CBPR training with the intention of learning from the communities we serve, in our case, specifically the Bronxville area, to help inform how we approach better delivery of palliative care. Because we agree that we first have to win the trust of the communities we want to serve. And one of the ways to do that, particularly for hospice, is early introduction of palliative care. And in the preliminary work we've been doing, we find that many of the people we talk to in the street do not know what palliative care is, or when they've heard about it, easily confuse it with hospice. So I don't have a question per se. I just want to thank you for what you've shared, and also want to put it out there that I would like to continue not just the conversation, but the relationship, so that we can partner together and do this necessary work. Thank you.
Yes,
Thank you so
thank
much.
you.
I will also, I'll try and put our emails in the chat, but following this, I'll reach out to Teresa and I'll send her a PDF of these slides, the survey link, and our contact information, and then hopefully she can disseminate it to everyone who registered, because we would love that. We would love to connect with you and engage in this work together and support each other and learn from each other.
Yeah, I'll just reiterate that 100%. And I think one of our goals at the HAT Foundation is not to repeat or step on toes or do work that other people are doing, but try to figure out how to collaborate so that we're all moving the needle on this issue forward collaboratively. I think that's the only way we're going to be able to really make impact.
Any other thoughts or questions?
I see someone in the chat asked for the reference slides, so I'm gonna
I
advance
see
to
his
that.
hand too.
Looks
And
like
then
Destiny.
Destiny, did you want to go ahead with the question?
Yeah, hi. I just want to say thank you for this presentation. I think this is something that everyone in like the healthcare field should know about. And so, yeah, I just want to thank you for your time with this. I really enjoyed listening to the different perspectives, and of course, like the negative historical aspect, although it's unfortunate, it's something that we do need to be aware about in order to prevent these instances from occurring again, and just to be aware of how, you know, the history of this all started. So I just wanted to ask, because I am like a pre-med student, I feel like there was such a, like, I took poli-sci, political science, so like I was able to get this kind of knowledge from those classes, but like I personally feel like there's such a lack of like understanding and awareness of like cultural competency and the idea of like making sure that you're really part of like the community that you're serving. And so my question, I guess, is, do you think that classes geared towards pre-health, or even when you are like in the nursing programs, in the like medical school programs, like what are ways we can kind of ensure people are learning about cultural competency and like specifically also like community health workers? Because I feel like the work you guys do is just really like so impactful and so necessary, but again, I just feel like no one really knows about it. So like what are ways we can try to include this in curriculums, especially at like the pre-health level?
Yeah, that's a great question. And I thank you, you know, for recognizing the importance of the work of CHWs. I think that any type of education is good, right? I think that cultural humility training, education about the legacy, the, you know, historical context of medical mistrust, all of these things are important for all of us, but especially people in healthcare. So I think if that education takes place in a classroom, great. But I also think that real world lived experience, specifically with community health workers. So I'm a big fan of the idea of, you know, having more interactions between community health workers and doctors or medical students or nurses to kind of share that perspective. I'm actually studying for my MPH right now. And in one of my classes, my professor talked about how she used to teach medical students, and she used to always have a class where she invited community health workers to come in, and the community health workers would describe to the medical students, you know, just like a typical conversation with a doctor when they give you all these instructions, and the gap in health literacy, that then, the people in the community are going back to CHW and saying, I don't know what this means. I don't understand what I'm supposed to do. And I'm intimidated to ask my doctor. So I'd say the more interactions we can have between clinicians and non-clinicians like CHWs, but also other folks in the community, like, leaders of faith communities or, other folks out in the community is a plus. I will leave it for Candace or Kim to add on to that answer.
I'll pop in and just add, I think it's such a multidimensional problem. I think that there are so many different places that it would be great to add in the education you're talking about, Destiny. And I think too, sometimes it feels like I'm just doing this little thing in this huge problem. But if we're all trying to do this little thing, then again, as a community, we can be impactful. In the research space, one thing Candace and I have become very aware of is the things we're learning in the current study that we're working through with NORC is information that will benefit the community. We're going to share it out and disseminate into the community, but it also needs to be shared broadly with healthcare providers so they can understand the perceptions and the experiences of people in the Black community. And so I guess one additional thought I have in the research space is just making sure the information is disseminated multi-directionally and as widely as possible. And then maybe having some space for conversation about it also.
There's any way that we at Curl can help connect you to our colleagues. We have Loyola has a School of Medicine, a School of, Public Health, a School of Nursing, social work. I think I'm getting, and then within the College of Arts and Sciences, multiple disciplines, psychology, counseling, psych, et cetera, et cetera. So if there's any way that we can help make connections for this presentation or something similar to be presented to our students and to our colleagues, faculty and staff, just let us know.
I would like to, thank you for saying that. I would like to present the research findings once we're done too, whether it's your staff or your medical school. I would like to do that.
Great.
That's great. Thank you for offering that, David.
Yeah, and I'll definitely be in touch. I always say Candace and myself and our other CHW colleague, Jenny, we will literally go anywhere and talk about this stuff. We would go to a church, a mosque, a synagogue, a school, wherever, and come, and it's always free just because this is our goal, right? You never know when serious illness is going to strike. So the more people that we can reach while they're healthy, while they're in a good headspace and kind of provide some of this information, we will do it. And similarly, when we talk about cultural humility and medical mistrust, we want to educate, clinicians and make sure, like Destiny mentioned, that they're aware of this as they go into and try and practice ethically and compassionately.
Thank you, everybody. I think we're at about time.
Yeah.
If anyone wants to stay on and ask some questions, we can keep it open, but I just want to be cognizant of that. So yeah, any final thoughts before we say goodbye? All right, I just want to thank you again for coming. This has been excellent. And I will get all those resources to folks. And yeah, you'll hear from us soon. And we look forward to learning more about the research that you all get out of NORC and those partnerships. So thank you again.
Thank you.
Thanks for having us.
Thank you.
Thank you. Thanks, everyone.
Have a nice day.